Milo Puhan, who will talk about the Swiss initiative. And yeah, tell us the latest news, please.
Good, thank you very much, Malcolm. Good morning, everybody. So the big question is how the evidence that you now saw applies to specific regions or specific countries. It's nice to know about the global evidence, but often you have little idea how this translates to a more local setting. And this is what the initiative is all about. So when the NLST came out, a group of pulmonologists, radiologists, thoracic surgeons, epidemiologists really started to meet to discuss what the results of the NLST may mean for Switzerland. And this effort was actually joined also by representatives from other big hospitals in Switzerland, and very importantly by NGOs, so the Swiss Lung League and the Cancer League joined this effort to together discuss whether to implement lung cancer screening in Switzerland or not, or whether to wait, and actually what to do. And we have actually two avenues that we follow. One is probably the most important one at this moment is to inform the public about the evidence and what we as a group think makes sense for Switzerland. So we do that by informing health doctors, but also the lay public through brochures, leaflets and talks. And the other part is that we tried to model. So we basically do one of these modeling studies we just heard before. We actually do that for Switzerland in order to project what it might mean to implement a lung cancer screening program in Switzerland. And the question that all of us are asking is really about the balance of benefits and harms, and I won't review that again, but what is important here, and I think also a little special in this lung cancer screening, is that the NLST showed both a reduction in lung cancer specific death, but also overall mortality. And this is, you may remember that this is one of the big sources of debate for breast cancer screening, where trials, admittedly mostly all trials, showed a reduction in breast cancer mortality, the screening trials, but not in overall mortality. And so the question then is always, what went wrong? Is it the harms that outweigh the benefits that were seen for cancer-specific mortality? So we can look at these more specific measures, but we always have to keep in mind to have something like all-cause mortality or quality of life of people to have an overall assessment of the benefits and harms. And I also mentioned here relief. It hasn't been assessed much, I think, in lung cancer, but those who have don't have a finding on the CT scan may be relieved. Others may feel anxiety and stigma, and these psychological effects also need to be taken into consideration, and these may differ a lot from country to country. So how these benefits and harms are weighted may be quite specific from country to country, and so this is why it's so important not to take just global evidence and make some global recommendations, but to really see what may make sense for a specific country and its population. So when you look at the screening, the whole sequence, and I really like to think not just about the CT scan, but the whole sequence, which is simplified here, admittedly. So we have to think how should we deal with all these critical pieces in order to maximize benefits and minimize harms. We already heard about eligibility criteria, which obviously play a very big role in the benefit-harm balance. Information and counseling, how well is that done? How much of an opportunity do people have to say, no, this is nothing for me? Dealing with positive or suspicious findings is one of the big topics, risk stratification, and finally how the whole follow-up procedures and interventions are done. You may remember that the NLST reported a very low number of harm events, surprisingly low number of harm events. When they looked at, and because there's quite highly specialized centers participating, when they looked at the harms across US centers in general, the harm was much higher. So you see again an issue of generalizability of findings that you may see in a trial where, let's say, the best centers of a country participate. And on the other hand, beside this, there are some really local circumstances that are probably key to figure out whether screening is beneficial or not. So each country has its own smoking history. The smoking history in Switzerland is not a very nice one. Although the smoking prevalence has come down from the 60s and 50s, where it was still up to 50 or 60%, it's still around 26% of the Swiss population who smoke, which is much, much higher than what we see in the US or in other European countries. And also how the types of lung cancer developed over time may differ from country to country. These are 30 years of experience from the cancer registry of the canton of Zurich, where you see that in men, I mean, it's probably hard to see that the incidence rates for the squamous cell carcinoma came down substantially, but adenocarcinomas went up a lot, which also account for a lot of the increase in incidence in women. But again, each region has its specific history and epidemiology of how these trends look like over time, and they are quite important when figuring out whether a screening may be beneficial or not. So a lot of things to consider when thinking about the benefits and harms, and finally also about the cost. So in a cost-effectiveness analysis, you look at the benefits and harms, but add in the costs. And again, here we have to ask for Switzerland, how would this play out for Switzerland? We probably have quite high healthcare costs, also indirect costs are probably higher than in most other countries. Smoking rates are higher again. So all these elements play into the equation when we try to come up with cost effectiveness estimates. So I would never take the results from Canada or the US in terms of cost per quality and apply them to Switzerland. Maybe we could do that for Germany, maybe for Netherlands, for Switzerland, but still it's a stretch. So we have to go to the local context in order to estimate the benefits, harms, and finally the cost. And you see here some varying results. These are not all cost effectiveness analysis, but the first three were done not based on the NLST. You see a huge range of estimates from one from Israel for $1,400 US per quality adjusted life years gained, up to over 100,000 in the McMahon study. So these were not based on the NLST, and some of them are a little intransparent on how they did it. But we have more recent results from the black, this is the NLST cost effectiveness analysis, and the Goffin from Canada, which you see are in the range from 50 to 80,000 US dollars per quality. But the big but again is, when you look at the subgroup analysis of this cost effectiveness analysis from the US, you see enormous differences again. So you see that, for example, in male, the cost effectiveness looks much worse than in women. You can look at different ages. So probably in the younger ages, the risk is just not high enough to be cost effective. At the higher ages, all the comorbidities come into play that may lower or may shift the benefit-harm balance. Smoking status, and all of that summarized in these risk categories for lung cancer, which show that the higher the risk, the more cost-effective lung cancer screening gets. On the other, this is very much discussed at the moment, like the use of risk prediction models to select those who are at highest risk. But again, this also comes at a big price. So this is where this screening paradox or prevention paradox may come into play. You may optimize a screening strategy for those at high risk, but you may not change anything at the population level, because the majority of cases may still occur in those at low risk, because there are many more of them. So this is also something we have to project. We cannot just look at these cost effectiveness analysis or relative risks or so on, but we have to see how a screening strategy plays out on a population basis. So I would personally argue about going for an extremely risk stratified approach, because it may not change anything on the population level. But this is something that should be modeled or predicted on a population level. and this is again where these models come into play. So single trials, neither NLST nor Nelson will answer all the questions we have about screening. But these modeling studies, and we saw some before, are very useful to ask the questions, what if? So what if we change some eligibility criteria? What if we add a good smoke cessation program? And so on. And this, you cannot do it otherwise than through these modeling studies where you have these different scenarios. So this is the MISCAN model, again from Rotterdam. So we are very happy to collaborate with the Rotterdam group for doing this analysis for Switzerland. And this, just in brief, this is actually a quite complicated thing and to some extent a black box. But what you try to do on a population level, what the incidence of lung cancer is, what the mortality of lung cancer is, depending on the smoking prevalence, maybe that changed over time, that differs across subgroups, depending on other exposures, depending on the demography of the population, and finally also on whether you use a screening program or not. So what you basically do is plug in the numbers you have from a specific country. You see again the key determinants of cost effectiveness, and then try to figure out incidence, mortality, and then finally the cost attached to that. And I think what is quite special for this study in Switzerland is that we have excellent cost data, which is quite, I think I have to mention that, quite unique. So we collaborate closely with Professor Stahel, and Malcolm Kohler is on board in this analysis, where we can use very, very detailed cost data of more than 1,000 lung cancer patients who were treated here in the university hospital. So often in this cost effectiveness analysis, you attach some unit cost. You say, oh, a surgery costs this amount or that amount, but often you severely underestimate all the costs that occur. And here we have really quite a unique opportunity to include all costs that really happens from the first, let's say, from the diagnosis of lung cancer. So these are not screen-detected lung cancer patients, but we have all the costs from the diagnosis up to the death in most patients. And this gives us probably a much more detailed view on costs, more realistic view on costs than what has been done in other studies. So this is the thing we are working on at the moment. Just one thing, we also are asked, should it be done in Switzerland or not? And here, just very briefly, the group currently really argues that this lung cancer screening shouldn't be left up to the so-called free market. You may have heard about ads in the US and in other countries that the low-dose CT, the low-dose CT is offered for free. You can imagine why this may be attractive for a provider to do that, but this is really very dangerous. It gets out of control very, very quickly, and this is why the group really argues if such a lung cancer screening program is ever implemented or tested in Switzerland, it should only go through a very standardized, quality-controlled process, similar actually to what Medicare does in the US. So they do reimburse the CT, but they attached very strict criteria to that. So there needs to be a registry where all the data about the patients, the procedure, the cost need to be collected so that you have the chance to improve over time, or to realize that you probably should stop offering this lung cancer screening for a population. So this is the current situation where we think if it's done, it shouldn't be I exaggerate a little bit, the Wild West, but it should be in a highly standardized, quality-controlled way. So to conclude, I call it, it's kind of a watchful waiting what we're doing at the moment. We try to figure out what could be the consequences for Switzerland by doing these modeling studies. We try our best to inform the public, let's say, the healthcare professionals, but also the lay public, the GPs who are confronted with this topic. And finally, I think I speak for many centers in Switzerland, we are currently not prepared to offer that. So it would require a lot of investments to really set up the whole sequence from counseling to treatment and do that in a very standardized way. And we are not in the position now to do that, and there are probably too little resources at the moment to set it up, given the uncertainty whether the whole lung cancer screening makes sense or not. So with that, I thank you very much.